Hi everybody, hope you're doing well. I am very excited today to announce that I have a wonderful guest today who's on my show that I was thrilled to be able to get. We are joined by Dr. George Michalopoulos, who is a board-certified chiropractic neurologist. What Dr. George does is truly amazing on so many evasive ways. And I think now, because of who I am, and those of you who watch me and follow me know I'm very, very spiritual, but I'm also about the mind, body, and spirit. And when I say that, it's very interesting to see how the body functions, how it works. And I always say, listen to your body when it speaks to you. Now, when the body is going haywire, that is a direct sign something is wrong. And today we are joined by Dr. George Michalopoulos, and you are going to hear some really wonderful, wonderful things, but things that will start to make sense. Thank you for joining me. I cannot say thank you enough.
Thanks for having me.
You are welcome. I was really excited when I reached out to you, and you said yes. As busy and renowned as you are, because people literally all over the world, they come and see you. Mm-hmm. And you're probably the most humble doctor I've ever met. And that tells me how you do this from the heart. The passion is real. Tell us exactly what it is that you do and what kind of patients do you treat?
So I am a board-certified chiropractic neurologist, and we treat a lot of complex neurologic cases, from concussion, traumatic brain injury, dysautonomia, POTS, vertigo, dizziness, migraine, kids on the autism spectrum. We have a branch of functional medicine too that we do with our functional medicine doctors. And basically, a lot of people will try and search what is functional neurology, mm-hmm. and there's really, you can't go into all the data banks of research and type in functional neurology, because there really is, this is just a simple term that uses to describe a variety of evidence-based procedures that are designed to increase human function. And this is what we do. This is what functional neurology is. It's a combination of the best of neurology, the best of optometry, the best of vestibular rehabilitation, the best of chiropractic, the best of massage, and we combine it in a fashion to try and help any neurologic deficits that we find in our practice. And there's things called ablative lesions that are obviously issues where there's permanent damage done. And then there's physiologic lesions, okay? And usually when people get MRIs and CAT scans, physiologic lesions will not show up on an MRI or CAT scan, and they say, well, I don't know what you have, but here, your migraines are being caused from, we don't know, but here's the medicine for it, and take that. And so what we do is we try to find out, where is that physiologic lesion? Where in that neuroanatomical pathway is the breakdown?
And you're coming to the root of it,
and we come to the root. Right. From a neuroanatomical standpoint, we want to find out exactly where that neurologic highway breaks down. Okay, where's the pothole that we got to fill in? Where's the, where the cones, where it should be a 4-lane highway, it's a 2-lane highway. We want to keep driving those pathways to make them as strong and as efficient and as neuroplastic as possible. So we basically create neuroplasticity. And we want to do it in a positive way. A lot of people that are sick have neuroplasticity, mm-hmm. but it's like a negative neuroplasticity. And a lot of times people will come and say, what are you going to do different than the best doctor in the world mm-hmm. that we saw mm-hmm. did for us? And I said, well, if he's the best doctor in the world, what are you doing here? So I want you to, people think that that there's no other options, and what we want to tell them is, look, there's options, and what our goal is with every patient is, or not so much our goal, but our intent with every patient is for them to give us just a couple of weeks. If they've been suffering for 20 or 30 years, okay, I'm asking for a couple of weeks, because what we do works quickly, and if it doesn't work in a couple weeks, it's not going to work in 10 weeks either. Okay?
You know, this is one of the reasons I was so blessed to have you on our show, because I'm all about education, okay? And I love doing my YouTubes because I always say knowledge is power. And there's so many fallacies out there that people have this intent of what they think it is or how they should believe. And we're here to enlighten that there are options out there. And there are, you know, you're sick, you're suffering, you've gone to so many different doctors, nobody's getting to the root, because I like that word because that's what you do. And I like to be able to give people the option that, yes, you know, you're not crazy. You're not making up these symptoms. Yeah. These symptoms are real. So where do we go? What do we do? You know, I remember when my daughter was diagnosed with verbal autism, or you can call it the autism spectrum disorder. And she was diagnosed this when she was about 5 years old. Okay, fine, you get the diagnosis. Where do you go from here? Yeah. Now, that, as a parent, is the most scariest thing that I could go through, having a very sick child, but myself being a very uneducated mother in this, you know.
In this world.
Yeah, in this world.
Yeah.
And I remember that feeling. It was the most helpless feeling. And I remember talking to the audiologists and the psychologists and all of them. And I said, so what do I do? They says, well, and they gave me some basic things, okay? And I'll never forget it. And I walked out of there like in a daze. And my mind is going, trying to figure it out. Well, I went into Operation Alex mode. I lived and breathed this little girl. I really did. I did. I remember picking her up from school. She was in kindergarten, and I was all day researching, and I was in my pajamas. And I looked at the clock. I says, oh my God, I got to go pick up Alex. I went into the car, and you had to physically take your child out of the, you know, carpool. Yeah. And the teacher sees me in my slippers and my pajamas because I was so into my papers and my research and trying to get my child better. So I think any parent could really understand what this is like. Yeah. So the fact of the matter, we've come such a long way, but in another way, there's so much that people don't know of what's out there. Right. So by having you and everything that you treat is a gift. And you are a gift to so many people, including myself.
Well, thank you.
So I just wanted to say that. So just knowing what it is you do and putting it out there for the public to understand. So that's why I say this is a video that I want to say to my clients, my viewers, please watch, and watch it with an open mind, and watch it with respect, and watch it a few times if you have to, because you're going to get things from this video that maybe you didn't get before. Write down things. I also want you to think of somebody else that may need this type of a video. Refer it to somebody, because like I say, when you do this, there is somebody, you know, unfortunately, there's always somebody we know who's had cancer. Well, there's always somebody that we know that has an autoimmune deficiency or a concussion or a neuro impairment of the mind. And it's important. We can relate to it. Let's help. Let's get the facts out there. And there are different ways to go about treating all of this.
So, and I know we talked about you know, the type of treatment. People have had the treatment that we do. Yeah. Okay. They've had vision therapy. They've had vestibular rehabilitation. They've had strengthening physical therapy. But the way that we combine it, it's a different fashion, and we really work more from a centrally mediated way than a peripherally mediated way. So, because like I said, we've had patients that have come in and said, well, I already did vestibular rehab, it didn't work. And I'll ask them, I said, well, what did you guys do? Did you do this exercise? And they say, yeah, I did that, didn't work. Well, that's the wrong exercise.
There you go. Okay. It was the wrong exercise. And here they're taking, you know, they're thinking they're doing the right thing, and then they give up. And I always tell my clients, there is something going on with your body. Pay attention to it. Your body is your temple. It's speaking to you. Please listen. Let's talk about your one patient who is such a beautiful little boy, about 12 years old, maybe, I want to say. And you were showing me the before and the after pictures. This boy loved to draw. And I was amazed to see the before you were treating him, and how he was drawing, and he loved to go into a room and just draw. Right. And after you treated this boy, and you had from before to during to after.
Right. So, so this young kid, he was a really sweet kid, very talkative, very smart.
And what did he have?
He was on the spectrum.
Okay.
He was autistic.
Okay.
And so, but you know, I mean, he was communicates well.
Yeah.
You know, we obviously did our neurologic exam, and a lot of these kids have poor gaze, the ability for them to gaze fixate, to focus on something is very bad. Okay.
Yes.
And so this is the key. This is like the foundation of the home, right? So if we can't fix that, if you're doing penthouse exercises and the foundation is crumbling, nothing's going to get better. And these are the type of parents come in and say, well, we already did vestibular and vision therapy and it didn't really work. What are you going to do? And I said, well, I asked them, what did you do? And they said, well, we did this, this, and this. Well, you know, this is like you're doing a super hard exercise, and you can't do the hard exercise. You can't lift 500 pounds if you can't lift 5 pounds. Okay? So you need to lift the 5 pounds first, okay? And so what we do is we start at the ground level, and we do the basic things like gaze fixation for this kid. So this kid finally was gaze fixating. He's following my thumb back and forth, which was spectacular, which is a big step for these kids. And the mom pulled me aside about a week or 10 days later and said, hey, Dr. George, so my son loves to draw. He's just I've got thousands of these pictures. I want to show you something though, because it's great for me, she said. So she shows me these pictures of this child that was doing like stick figures. They're almost like beautiful, like brown and colorful, but they were stick figures with a long dress. And then she shows me another family of 5 stick figure kids, and all stick figure, but really pretty, okay? And the next day she shows me this piece of artwork that he said he drew this, and it was very detailed and very shaded in figures, and you know, very outlined, almost 3-dimensional faces. And she said, do you think that what you did might have caused this? And I said, well, I don't know, but what I do know is that his brain's getting better, so maybe this was one of the layers of the onion that we peeled off that allows him to do this stuff. Okay, so there's things that could have been coincidence, okay? But the only thing they changed was coming here for 2 weeks. So the mom's convinced that you know, we basically turned this young man's brain on for him to be able to express his creativity and do these phenomenal pictures and artwork. So.
I when you showed me this, it was just no words can express it. It's 1,000 words right there in those photos. Yeah. And yeah, that is due to you. It's due to the techniques and the therapies that you used on this boy, and like you said, you only had a couple of weeks with this boy, and there you go. Yeah. Coincidence? I don't think so. It's not about the money as much as it's about the results. And I want to talk to you about very different things that you cover. And I know a lot of it is, for one thing, concussions. And because our society is getting more and more educated on the concussions. I mean, I remember when Will Smith made that movie, Concussion, it set a soar of people really not realizing the effect and the damage a concussion can do to one's brain. Am I right?
Absolutely.
Okay.
Yeah.
So you get a lot of patients that have concussions. What is it that you do? How do you assess them?
So usually more than usually, we're not the first people that these concussed kids or adults come to, whether it's a car accident or actually a sports-related concussion. We're, 5 years ago, we were the 20th or 30th doctor, okay? And by the time they got to us, they'd already been through everything or nothing, okay? And so I think the old way of treating a concussion was, look, just rest for 30 or 40 days and your symptoms will go away. And that's, even to this day, that's true, because 75% of concussions, if you get a true concussion, that percentage, okay, the symptoms will actually go away. So if you have brain fog, or you have headaches, or you have blurred vision, or you have stomach issues or difficulty sleeping or anxiety. A lot of that stuff will go away in about 70% of the cases. And the fact is that the symptoms will go away, okay, but there's underlying objective things that are still there. So that's why a lot of these kids that go back to return to play sports, or maybe they're not an athlete, maybe they were in a car accident and just got whiplash and you said, I got this brain fog, and somebody just kind of slapped them on the back, and then all of a sudden they go, oh my goodness, all my symptoms came back, okay, from something that was so minor, and said, how could that happen? I didn't get a football helmet to the head, or I didn't get a cross check from behind. It was just like my buddy, we were just horsing around and all my symptoms came back. How does that happen? And the way that, by the time the patient comes to us, the second time it happens, okay, now they're in this spiral of I can't sleep, or I'm sleeping too much, or I can't focus, or I can't concentrate, I can't read, I have light sensitivity, sound sensitivity, headaches, all the symptoms that are real. Brain fog is a big one, and all these symptoms now come back, and these kids, 15, 16, 17-year-old kids that are maybe seniors in high school, get very stressed out, and what ends up happening is they can't finish school. They're afraid they're not going to get into the school they want to get to. So now it gets to a point of desperation where the parents said, we went to Mayo, we went to Northwestern, we went to here, went to there, went to our family doctor, went to the pediatrician. They said rest. We took the medication for the headaches, and all those things are good. And my goal is to make people understand that, look, there's other stuff out there.
I agree.
Okay?
I agree with that.
There's other stuff out there that is like what we do is called functional neurology, and you can go on PubMed and search the term functional neurology. You'll find nothing, okay? Because functional neurology is really it's a simple term that kind of describes a variety of evidence-based procedures, okay, through research, evidence-based, peer-reviewed, high impact research that's designed to improve human function. And that's what we do, okay? So a patient comes in and they say, I've got brain fog, I've got this, I've got that. And so our job is this. They're going to come in, we have a 20-page questionnaire that we fill out from how did the injury happen, what's going on, psychologically, what are you doing? I just came back from just an amazing advancement in TBI and traumatic brain injury, advancements and updates that we learned about these consensus. Okay, the consensus papers that are out in the world that are, this is the standard, this is the gold standard, okay? And these consensus papers say, hey, this is what the definition of a concussion is. This is what you have to do if a child or an adult gets knocked out, or you see them wobbly, or you see them in posturing, in a certain posturing, tonic posturing. You have to pull them off, evaluate them. They cannot return back to the field. Okay, so there's certain criteria. There's other things that talk about how if you say we're predisposed to or have a genetic predisposition or epigenetic predisposition to depression, and you're not depressed and you get a concussion, high probability you're going to get depression.
Really?
Okay.
Interesting.
Or if you were depressed, it can actually increase your depression. And there's papers out there that after you start, that's why it's important for the whole family to come in. And so because now there's research out there that says, hey, that if you positive talk to the patient, okay, this will have a high impact on this patient recovering. But if this patient says, oh, I can't get out of bed, I'm sick, I'm this, I'm that, and maybe the mom or dad says, come on, suck it up and get out there.
Which most do, because they think they're being lazy.
And what ends up happening is that squashes this area of the brain called this dorsolateral prefrontal cortex, and now they go into a deeper depression, or they go into a deeper anxiety, or they go into deeper symptomatology, right? And there's certain things that are evidenced by this thing called this functional MRI that shows that all these concussions lose that input in that area of the brain that involves working memory, this dorsolateral prefrontal cortex. And so when they do it, when I ask you a question, let's say you're fine, you got nothing going on, we stick you in the MRI, we ask you a few questions, what day is it, what time is it, this will light up, this dorsolateral prefrontal cortex will light up. But when you have a concussion, and I ask you that same question, even if you get the answers right, a different area of the brain will light up back in here. Okay, it's called this parietal occipital lobe. And so now we know that this frontal lobe, okay, is in demise. So now our job is, you come into my office, we're asking these pretty poignant questions on this 20-page questionnaire that we're trying to cut down, but every question is important. And now we have kind of an idea of what's going on, maybe the mechanism of injury. Is it a female versus male? Because females are treated like, were, at least in the past, treated like second-hand citizens. Oh, you're not really, you don't really have, you're just weaker. Well, the fact is that a lot of injuries in women, concussions, involve the neck, and that was a big part of this consensus statement. And these tests called the SCAT-5, which involves balance testing and neurocognitive testing and a whole bunch of other tests in there that can say, hey, look, this is a good baseline. This is what we need to improve on. Yes, you have a concussion.
So, okay, with that, what are the different reasons to getting a concussion? It isn't just that you're having an actual accident happen with your head.
Well, the actual definition, okay, of concussion, according to this Berlin consensus, this is a big deal. This is what everything is, the sports-related concussions, right? And we can probably transfer that to, say, a whiplash injury, except for it's a bit of a different type of mechanism of injury. But sports-related concussion is a direct blow to the face,
the
face, or the head, okay, or the body that transmits mechanical force to the brain and causes this injury.
Okay,
right? So if I hit you in the chest with my football helmet, okay, I didn't hit you in the head, but what happened was you went like this, and then your head your brain is like it's like a balloon, okay? So I've had the privilege of holding a person's brain that just died 24 hours ago before it was put in formaldehyde.
Wow.
Okay, and
what was that like?
This is like life-changing, okay? To hold actually the brain. It was in and I just did this a year and a half ago, and I've been practicing for 30 years almost now. And so all the brains that I've dissected have been in hard. People know what a brain looks like. It's like rubbery, it's solid, and the reason it's solid is so you can cut and cut certain slices so you can see certain areas of the brain. Well, a brain that's not in formaldehyde, okay, is once you take it out of that blood-brain barrier, which is the saran wrap that molds the brain into the shape that you see, is like, have you ever seen the green slime that the kids play with? Okay, you put it in your hand, it goes through your fingers, okay?
Yeah.
That's the texture of the brain. That's the consistency of a real brain, right? So imagine having that in a balloon.
Oh my God, that's fragile.
And it's super fragile. And it's very malleable too, especially at a young age. But you do that, you get this concussion, even if you don't get this, say, subdural hematoma, where you get a massive hit to the head, you get a bleed, you just get this transmitting of this mechanical force. What ends up happening is it's just like me just giving you a punch in your arm. Okay, very soft, doesn't have to be hard. And what you'll do is you'll damage some of the tissue on the inside of the brain. And as that gets damaged, it's just like if you somebody punches you in the thigh, okay, your immune system now has to go down to the thigh and say, hey, there's some dead red blood cells, let's just clean it up before you produce this autoimmunity. Okay, so the immune system wakes up, it goes down there, it cleans it up, and now you have this clean site, you get a little scar, and it, if you got cut, let's say, and it heals, okay? The brain has its own immune system. It's so important, it's got its own immune system. And the brain is encased in this saran wrap that we call this blood-brain barrier. Okay, and that blood-brain barrier, the saran wrap, okay, I hope everybody knows what saran wrap is.
The plastic film.
So, yeah, I'm from Canada. We should call it stretch and seal.
Stretch and seal,
stretch
right.
and seal is a Canadian word for it. So the saran wrap has its own neurons, and it's a neuronal cover. Okay, and the neurons in here are called astrocytes. So these astrocytes are like security guards, and they're like soldiers. They're waiting. They got their machine guns, and they're waiting and wait. They do nothing. They just wait and wait and wait and wait and wait. And the second you get this trauma, okay, that say alters the physiologic chemistry inside the brain, which is through this transference of mechanical force into the brain, okay, and you stretch these neurons internally in the brain, not the astrocytes, okay, what happens now, these soldiers knock on the door, and they go, hey, let us in, something's going on inside. And so now that the astrocyte, and this is very simplistic, but this is the way I think that people will understand this. This blood-brain barrier now will stretch just a tiny bit. And the reason it stretches is because the second it stretches, it'll activate another set of neurons inside the brain called these microglial cells. And the microglial cells are the immune system of the brain. And so these microglial cells, they were asleep for a while too, right? And now they wake up and go, hey, what are we doing here? So now they're going to survey the landscape and the internally and say, hey, look, what's going on?
They're like in a fog.
They're like, they woke up to see where's the dam, what's going on, why did we wake up? And so just like the cut and they trying to decrease the or get the injured tissue away. They're going, there must be some injured tissue away because we're awake, right? So now they survey the landscape and they go, okay, you're a good neuron, you're a good neuron, you're a good neuron, you're bad, you're broken, you're dead, you're good, you're good, okay? So we're going to keep all the good guys and we're just going to prune the bad guys out, okay? And so this is a good thing, okay? So this is how you're trying to prevent, say, an autoimmunity within the brain too, because you don't want this response on dead brain tissue, so you got to get rid of it, right? So now, the problem that happens now is that this brain, okay, to activate the immune system, what had to happen? The blood-brain barrier had to stretch. But now this blood-brain barrier, okay, that's stretched, is not saran wrap anymore. It's more like a screen door. So now any of the environmental stuff, okay, that saran wrap is a protective mechanism to keep all the good stuff in, keep the bad stuff out. Now there's some exposure, right? So if you've got issues, if you've got environmental issues, or you're breathing mold, or you're breathing you have an allergy, or even if you have a food sensitivity that you don't even know about,
right?
Now these things have access to get through the screen door, and as your brain's healing, now you can get metabolically reconcussed, okay, without getting another hit to the head, without getting another, and your brain's going, hey man, we're trying to heal this guy, and now he reconcussed us, and we don't know what's going on. So now you get this ramification of all this, the immune system on all the time. So you don't want it on. You want to shut it off. You want it to rest, okay? So you want to heal appropriately. So by the time they get to us, they feel the brain fog. They feel the headaches. They got gut issues because there's a direct relationship between the brain and the gut. They can't sleep, or they sleep too much, or they're depressed, or they're anxious. But a lot of these studies that are coming out now say, hey, this is why you're depressed, okay? This is why you're anxious. This is, and a lot of people now, the movie Concussion you talked about,
right?
Every word in that movie was the truth.
Oh, I know.
Okay.
That's why I love the movie, because it was bringing it out. They were trying so hard to cover so much and not alarm people, but I think power is knowledge is power. But that brings me to the next thing I want to ask you. So with all of these things that the brain kind of piggybacks from, what happens? What about what we put into our bodies?
Well, that's another thing too. I mean, so the key is, like with concussion, okay? Any acute concussion, we now get parents calling, like they're playing hockey on Saturday.
Right.
Kid gets concussed Saturday afternoon.
Yeah.
They're texting the office Sunday morning. Oh, my son got a concussion. I need to get him in right now.
Right.
Well, we can't really do too much in the first, week or so. Okay. But what we can do is there's a lot of great things you can do. Number one, the most important thing you have to do is you need to decrease your caloric intake. Okay?
Which is?
Just, if you're eating 2,000 calories a day, eat 1,200 calories a day.
I see, okay.
But the foods that you have to eat have to be high fat and high protein, no high glycemic carbohydrates at all.
Really?
No sugar, Okay, you have to totally wipe sugar out.
So the first week, you're saying?
The first 72 hours at least.
Okay,
right? So
interesting.
This is what we do. And the reason is because sugar will not allow those microglial immune cells to do their job, to eat. You need to fast to make sure that they eat the junk. Okay.
So, when you hear,
fuels a fire.
Right, but I was always taught, and I've always heard, when you have a concussion, you can't go to sleep for the first 24 hours, keep the person up, and well, that's what I always heard.
Yeah.
Okay, but I never heard that before.
Yeah, sugar.
Yeah,
sugar.
Diet.
Yeah, diet is huge. I mean, we do that, and the other thing that you have to do is you have to take omega-3, a high quality of omega-3 fatty acids, including DHA and EPA, right? So there's a great book by an MD. He's a surgeon. I think he was in he's in the military. I can't remember what branch. It might have been the Navy, but he was a surgeon, and he treated a lot of these blast injured patients that had traumatic brain injury. And his whole thing, his name's Michalopoulos. Dr. Michalopoulos is an MD. He talks about just tons and tons of omega-3s, like 10,000 milligrams a day for the first week, then down to 6,000 milligrams a day the second week, and then 3,000 milligrams a week forever.
I'm a big advocate for what we put into our bodies. I really am. The older I'm getting, the more. I mean, I'm dairy-free, I'm gluten-free, and my joints don't even hurt. I mean, sometimes they do, but nothing to the degree that I went through. And I have to say, I think what we put into our bodies, especially foods that are filled with chemicals.
Yeah, chemicals. Listen, I think my view on chemicals is, I'm going to go out on a limb and say, listen, I'm not anti-vaccine, I'm not anti-chemical preservatives. I mean, I don't want to do it, but the thing is that obviously if something is synthetic,
I agree.
that the body does not make on its own, is going to be a foreign particle, a foreign object to it, so the body's going to want to get rid of it, But after a while, once you exhaust the dump trucks that take all that stuff out, you're going to say, okay, maybe he needs this thing. Okay, so now this is where you get all these changes, these genetic changes and epigenetic changes, and all these other issues that happen with methylation, which I'm not a big I don't know anything about functional medicine. That's our other guy. So I know about what I do. But
all right. So looking at that, it opens the door for me to ask you, what about autism, Asperger's, Parkinson's, dementia, stroke? That all falls under neurological. So there's different facets in repairing that, not just concussion.
Sure, absolutely. Yeah.
I mean, we know that concussion sometimes leads to early dementia. I've been reading about that.
I'll tell you this. This is as far as, let's say, Parkinson's goes. There's ways. And this is like I said, this is evidence-based stuff. This is not George research.
Right.
This is from Harvard and Yale and Northwestern and Mayo and the best universities around the, not just the U.S., in Europe and in China, all over the world. And there's ways that you can detect some signs of Parkinson's as early as 15 years prior to the person getting this, say, hand tremor.
I don't think that you can, I think maybe for some people they can get a hand tremor if they were blown to the head very, very bad or an explosion. I do, but I think I really agree with that. I think it's a process that has to build up. So when you're saying 15 years, I agree with that, only because it takes time for the body to acclimate to get it to that level, unfortunately.
So with, let's just take Parkinson's, for example, which is a progressive neurodegenerative disease.
And you're going to see a lot more of it. That was my prediction.
Yeah,
I believe that. Unfortunately, I do believe in that it's going to get a lot more, and it's going to be, I hate to say it, but 20 years ago, 25 years ago, a lot of people didn't hear too much about autism. It was there, but it wasn't. And then it became more of the norm. 199, now it's 1 in 10 or whatever it is, whatever the statistics are. But I see that happening for Parkinson's as well.
Yeah, Parkinson's is very interesting.
Yeah.
Because not only can it happen, I mean, there's research that's showing that you can get neurodegeneration and CTE from concussion and these hits to the head. But what the process that occurs is this thing called hyperphosphorylation, which is basically that process that I talked to you about. This immune system trying to clean out all the junk. I mean, we all have what's called tau. Okay, in our brain. Okay, tau is kind of the building block for dementia and Alzheimer's. Okay, so, but your brain clears it out. Okay, but if you get this hyperphosphorylation, you produce these proteins that now your brain can't clear out, or it gets behind. It's almost like, you know, Lucy on the belt trying to eat all the chocolates. Okay, and all of a sudden the belt's going faster and faster and faster. She can't eat all the chocolates, and say, okay, we will give up. Just, you know, and so now you get this protein buildup that causes this. It's almost like a short circuitry in the brain, and now they become demented, early demented. Okay, but there's things that you can do that when we do our exam. Okay, like I said, the patient coming into our office, we do this full history, and then we do a very thorough neurologic evaluation. Okay, it takes us about an hour for the actual hands-on evaluation, but what we're doing is we're checking the afferent pathways, the sensory input pathways. We're checking the cerebellum to see how well can you accurately move your eyes, how well can you have balance, how well are you coordinated, what's the ability for you to hold gaze. Okay, then we check the brainstem from the medulla to the pons to the top part of the midbrain, and then we check every corner of the brain. Okay, the frontal lobe, the parietal lobe, the temporal lobe, the occipital lobe, and the way we do this is through this system that that everyone learned in medical school and chiropractic school, and we check the vision. Okay, we check the vestibular system, we check the proprioceptive system. So what does that mean? That means if I turn my head to the right, okay, my eyes go to the left. If I turn my head to the left, they go to the right. If I go down, they go up. If I go up, they go down. And so that's the visual system. Okay, the vestibular system, okay, is this. If George and Susan are in a car, and I say, Susan, I want you to close your eyes. Okay, and we're driving, and I'm going to turn right or left. Okay, with your eyes closed, you should be able to tell if I'm turning right or left.
Which shift is going.
Yeah.
And a lot of times people can't do that.
They can't do that, right, especially when they have a concussion. Or if we're in an elevator, so that's angular acceleration. Or if we're in an elevator, I say, Susan, listen, you know, I'm going to tell you right now, we're on the 10th floor.
Yeah.
Okay, and I want you to close your eyes, and I'm going to push either the 20th floor or the first floor. You should be able to tell if we're going up or down. Okay, so that's a different part of the vestibular system, but we will analyze and examine that too. So angular acceleration, visual acceleration, and then the last part's the proprioceptive system, which is kind of the force of gravity tugging on your muscles and saying, you don't feel this, but you feel that, you know, that I'm not floating in the sky, okay? And you know that this chair that you're sitting in right now is not one of those Three Stooges chairs where it's going to go like this and you got to catch yourself, right? You know that your butt is sending a signal to your brain and saying, I'm pretty confident this chair is not going to break.
Right.
So I'm just going to relax all my muscles. I'm going to be all cool. Okay. So what happens is now, if I turn my head to the left, to the right, my eyes go to the left. The second that happens is the visual system sends a signal to the brain and says, hey, George's head is moving. Do we need to protect him? Is he falling? Let's go to the vestibular system. Vestibular system says, nope, you just turn his head to the right, just contract these muscles. Proprioceptive system, what's happening? He's just sitting down, so you don't need to do anything else. So the only thing we have to do is contract these muscles in the neck to turn his head. That's it. Okay? If we're on a tightrope, though, okay, and we're balancing on a tightrope and going like this while you're, again, the system is, the eyes are going, hey, he's moving. Do we need to protect him? And the vestibular system, what's going on? Well, he's going up and down, side to side. Contract this muscle, contract this. Proprioceptive system. Well, he's got a little bit of input on his feet because he's on a rope, right? So contract this, and you're balancing out. He's not falling. He may be falling, but we're contracting these muscles. Okay. So the thing that we look for right now is when we do our diagnostic testing, which is we measure all aspects of eye movement. Okay, and now if your eyes, and we videotape this, okay, we'll have a patient look straight ahead at a dot, or actually we'll have them look straight ahead in the dark, eyes open with a cap on, it's in the dark, And if their eyes, we say, look, we just want you to pretend you're looking at something straight ahead, they should be able to focus or gaze stabilize, have their eyes not move. If their eyes are moving in the dark back and forth, while they're sitting there looking straight ahead, the brain gets the signal, says, hey, George is moving. Okay? Vestibular system, what's going on? Well, nothing. He's looking straight ahead. So there's no input. The receptors aren't getting lit up there. Proprioceptive system, what's going on? Nothing. Okay? He's just sitting there. So now the brain gets confused. And it says, look, we've got this input, okay, but the vestibular system is saying we're not moving. The proprioceptive system is saying we're not moving. So what we're going to do is we're going to tighten this neck up. Okay, so tight because we want to stabilize the head on the body to make sure that he doesn't hurt himself because we think he's moving. Okay, so this is exactly like, have you ever sat like at a red light?
Yeah.
Where you're sitting at a red light and you're waiting for the red light to turn green and you're just waiting and waiting. You got your foot on the brake, okay, and you're waiting. There's a car next to you. And all of a sudden, this car next to you just kind of just rolls back a little bit. You slam your foot on the brake. You ever done that? That's called a sensory mismatch. Your brain played a trick on you. Okay, this is the exact same thing that these concussion kids are going through. They have sensory mismatches.
I feel bad for them.
Yeah, that we need to correct. Okay.
Well,
you can't correct it with medication. You can't correct it. You need to correct it through very specific, and I can go into this.
Therapies.
Therapy. Very specific,
and
either vision, vestibular, or proprioceptive therapies, right?
Your office is amazing, by the way.
Yeah, thank you.
You have the state-of-the-art equipment.
Yeah.
And I have to say, both my producer and I, we were like, our jaws are dropping. And, I've been here many times because you had worked on my daughter as well, and you did an amazing job on her, because I remember my daughter when I gave birth to her, she was a forceps baby. She always had a problem with her neck and her back. She developed this curvature. I mean, she had like a round ball right here. And I remember she came, there were a lot of sessions, that she came. And it's completely gone.
It's awesome.
And you worked on her.
Yeah.
It's funny because I had another friend of mine, I call her my adopted daughter, and she cuts hair. And when I went to see her, she could not stand. She couldn't, it's like being on a cruise ship, and she was wobbling.
Yeah.
And I said, Jen, what's wrong with you? She says, Susan, I went to Las Vegas with my husband, and when I got off the plane, something's wrong with me. I don't know what's wrong. And she started to cry. And I felt so bad for her. And I said, your equilibrium is severely off. She says, Susan, I don't know. Do I go to a neurologist? I says, well, it depends who you're going to. And I'm very funny about that. I have somebody for you, and and I remember I reached out to you, and you were wonderful. You reached out back. Since then, she went to your I think it's the Chicago location, and it's gone. You worked on her. Yeah. So, people that are listening to this, even vertigo is something that could be really important, but can be corrected.
Right.
You can do that.
Yeah. So yeah, vertigo is another like vertigo, dizziness, vertigo. This is part of concussion also. Right?
Oh, is it?
Absolutely.
Now she didn't get. Again, I'm going to bring this back. She didn't get a blow to the head.
Yeah. She had what's called a centrally mediated vertigo, okay, which is not a peripherally mediated vertigo, which basically means that when you get, like some people will get out of bed and they go, oh my goodness, it's spinning, and then if they wait for 30 or 40 seconds, okay, the spinning goes away and they get up slowly, and if they move too quick, that is called the Bppv, okay, which is called benign paroxysmal positional vertigo, and that is the effect of these certain crystals that are used as weights, okay, that go into a wrong canal that give you the perception that you're moving because this crystal has weight, right? And the weight is in this fluid, and what happens is if you put a weight through fluid, it's going to actually cause pressure, and it'll hit this receptor that says, hey, you're moving. And the way we can figure that out real quickly is if the person has nystagmus in the eyes. And we can put them in that position. And when we do that, with these Bppv cases, which I think are like 75 or 80% of dizziness is Bppv. Okay, so it's simple. This is a 5-minute treatment, okay? Once, maybe twice, and done, okay? So if you have this simple vertigo, that's one thing. But if you have centrally mediated vertigo, where these crystals are not involved. Now we got to figure out where's this coming from, because you have these things called these vestibular nuclei that fire up into the limbic system that can cause depression also, and it'll give you the perception that you're moving when you're not really moving. We have people that and this is a tougher case, of course, this thing called Debarquement Syndrome, where people will go on a cruise ship for a week and they come off and they feel like they're still moving. Okay, the reason they feel like they're still moving is because it's almost like you created a new neuroplasticity in this equilibrium system. Even though the ship doesn't feel like it's moving, the water's moving that ship. Okay, you don't feel it, and gets transmitted to certain areas of this vestibular system. And once you get off on hard land and you're walking, go, "Ooh, I feel like I'm moving all the time." Okay, usually it goes away pretty quickly, 5, 6 days, 2 days, 3 days, or no. People don't get it.
Right.
But sometimes stays for years.
So
that's more of a central issue.
Okay, but what I'm getting, and I'm really getting educated here, is basically if you're not right, you're saying to wait about maybe 6 or 7 days. And
after
then
concussion.
After concussion, come see you and start to get to work. Because there has to be work in reprogramming what's happening.
Right.
The weakness to the brain.
Right, exactly.
The longer it goes on,
yeah,
the more damage is happening, or does it just
maybe,
kind of
maybe,
sit
maybe
that
not.
way?
I think it may sit that way. It may get worse. Okay, it may get worse. I don't know if it gets more damage. It might get more damage. The key is, look, the faster we get it, okay, I think the easier it's going to be for us to treat it. Ideally, this is what should be done. Okay, all these young kids should get real objective baselines done. There's some neurocognitive tests that kids can game, okay, because they want to play the game. So what they'll do is they'll purposely go slow, so they get a lower score. So if they do get a concussion, they know that the only way they can get back in the game is if they do this test. They have to beat the score of their baseline, right, or meet the score of their baseline. So if they don't meet the score of their baseline, that means they can't play. Okay, so what they'll do is if this is the first time they did it, and this is a game, okay, so if this is the first time they did it, they're going to purposely try and beat the computer and try and get as high score as possible. If they get, say, for example, a 90, for example, and they get a concussion, and the kid says, "Yeah, coach, I feel good. Go back and do your test, okay? And if you get a 90, you can go play." And the kid gets an 80 because I can't let you in. Now the kid gets upset. He's got missing games. So every year they have to get this baseline that is gameable.
Just enough.
So he's going to go slower, and he's going to get a 70. So now he knows if I get a concussion, I know I can beat it. I can get at least a 70 even with my concussion, right? So now these kids, and they don't understand how damaging this is in the future.
I agree with you. What are your thoughts about helmets?
So helmets,
because there's a mixed thing. I know certain states require them and some don't.
For football?
Well, even for motorcycles.
Yeah.
Okay.
So here's the deal. Helmet. The purpose for the helmet is not to prevent you from getting a concussion. Okay, the purpose of the helmet is to help to the best of their ability to prevent you from getting a skull fracture. Okay, so
big
the
difference.
problem is you get these kids that have these $1,500 and $2,000 football helmets that go, "I'm protected now. I'm going to use my head as a weapon in the game and try and hurt this guy or try and be the best football player possible." The problem is that the helmet is only protecting him from getting a fracture, okay, and possibly a subdural hematoma, but it does not prevent the brain inside this water, okay, the cerebral spinal fluid, from going back and forth, okay? Because if you have a helmet on, you shake your head back and forth, okay, your brain's moving.
And I remember at the earlier of the segment how fragile the brain is that you held in your hands, and now you've got a helmet on it.
Yeah. Now you're thinking, "Oh, I must be protected." Well, your cranium protects the head. Okay. The helmet protects the cranium. Okay. It does not protect the internal structures, except for, like I said, for a skull fracture or subdural hematoma or those big ablative injuries that could happen, subdurally, let's say. But the tissue, the physiologic, it doesn't prevent a physiologic lesion. It doesn't prevent the issues that when you get a concussion, you go and get an MRI done, the majority of them come back, you're normal. There's nothing wrong.
Why is that?
It's because It's because an MRI and a CAT scan are meant to pick up the lesion, the big fractures and the subdural hematomas. There's no way that they can pick up a physiologic lesion, this pathway that helps this neuron live. Okay, it's not going to, unless you do these new diffuse tensor imaging, okay, which I know these beautiful pictures of these brain pathways that come in, but those tests are $5,000 and $10,000, okay, and it's not to market yet. It isn't to market, but it's not. It's not feasible.
But you're not digging deeper.
No, exactly.
And that's what it is. And sometimes I'll have a client that'll come in my office, and I am picking up because I get symptoms of what they're going through. It's actually affecting my body physically, and that is spirit literally telling me you need to feel it so you could talk about it with them. So I'll say, there is something going on with your head. My head is like excruciating pain.
Yeah.
Well, I had a CAT scan, I had an MRI.
Negative.
Yeah, I go dig deeper.
Yeah.
Now, I've had clients that have come back and said, oh my God, Susan, they found X this, X that.
Right.
So you're right on that.
Yeah. So the way that we can pick up these physiologic lesions is through our diagnostic testing and our exam. Okay. So
do you do them here?
Yeah, we do them here. We do
great.
This thing called.
So this is like everything is here.
Everything's here, right? So we can check. We can check every corner of your brain. Okay. We can check your frontal lobe. How do we check frontal lobe? Well, we can ask you questions. Okay. We can say, what day is it? What time is it? What year is it? And see how fast you answer them. But we can also check your eye movements, okay? So if I say, hey, Susan, I want you to look at my nose, and whichever thumb I flick, you're going to look at it. Boom, 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 boom. I can record the eye movements, so I'll put these goggles on. It's called a video oculography, a VOG or VNG, video nystagmography machine. It's called VOG is now the new term. But so you put these goggles on, and these goggles now will do it, and it'll record your eye movements. And what we're looking for is how accurate are you when something lights up here? How accurate can your eyes hit that target? Okay, this gives us information as to the integrity of that frontal lobe. How, and not only the frontal lobe, but also its connections to allow this to happen. These things called burst neurons in the middle of the brainstem, and the cerebellum. How does the cerebellum stop the eye from jumping to that point? And then you'll go this side, and it says, okay, how fast did he go? What was the accuracies and the latencies? Okay, latencies are huge. Latencies give us an indication of how fast you can react to a stimulus. Okay, and this is very, very important because the latency is this. There's a light on here, okay? The light will go off, and then you have to whip your eyes over to this side without moving your head, just eyes only, right? So the latency is the second that this light goes off, the timer starts, okay? That light that's now off has to get transmitted through your pupil, through your retina, through the optic nerve, to the thalamus, to the occipital lobe, to the prefrontal cortex, to the frontal lobe, and say, hey, we have to do something. What do we have to do? I have to make a decision to jump my eyes to this target. The instantaneous second that my eye starts to move, the timer goes off, okay? And now we've got the time from here to here to here. This time has to be from the neurology books, Lindsay, the father of neurology, and all these, Dr. Sheikh and all these guys that do all this research, says that this time has to be under 200 milliseconds. If it's over 200 milliseconds, we have an increased latency. Our job, decrease the latency so it gets to the point where it's under 200. And we have also, I've got beautiful pictures, well, they're not beautiful, but I have pictures of latencies of my uncle, okay, who I love dearly. He's got Alzheimer's, and my dad's brother. So I saw him 4 or 5 years ago, okay. Remember, this latency had to be under 200 milliseconds. Okay? His latencies were 1,400 milliseconds. It took him 1.4 seconds to recognize that this light's, I have to do something. What do I have to do? I don't even know. By the time he'd get to this target, it was already off, so he was going back and could see all these different latencies that show us, hey, look, this is not good. Okay.
I have to ask you, it's really interesting. You brought up your uncle, and it's a great point about Alzheimer's. What do you do with somebody like that? Is there anything you could do?
Yeah, you know what? I think the key is, getting them as early as possible.
Across the board.
Across the board.
Right.
Or, like, even if we have baseline tests for people that are worried about Alzheimer's, okay? Let's say my uncle had it, my cousins had, my aunt had it. So just do baseline tests just to see what is the integrity of my brain. Okay, and there's ways you can measure. There's measurable. It's objective findings. This is not like, some tool at Macy's that we can play games with and check this. These are objective findings. These are measurable findings.
I love
games
that.
now. There's games now that you can get.
Yeah.
That we're going to implement in our office, and I can't remember the exact name. I think it's called EQ. Okay, so this game, okay, can measure these kids. These are fun games that measure the integrity of these kids' brains. Okay, and they all the data comes back to us. And if the mom sees that, hey, this kid's brain is going down, then we want to get him in to see what else we can do to fix him up, and we'll come in and say, okay, we'll do this, and this, and see. And these games measure. It's like a fun game that measures reaction time and speed.
So cool.
And
you know, I'm looking at it. You're telling me it's preventative maintenance. So people could actually come in. I mean, I would do this for me, and see where I am.
Yeah. See where you're at.
And you would be able to do that.
Yeah, of course. Yeah.
And
so
you can
it's better to always do the baseline. Before,
right.
I don't want you to come in here when you already have Parkinson's. Okay?
No, right.
Because then you make my job hard.
God, that's fascinating to me. So people could actually come in, do preventative checkup maintenance of their brain. In other words, don't wait till something happens.
Yeah.
Start seeing it ahead of time.
Right. Just like even with Parkinson's. I know you mentioned Parkinson's. You're pretty passionate about that.
I am.
So Parkinson's is basically a neural degeneration of this area in the brain called the dopamine pool. So it's in the top part of the brainstem. Okay, it's called this midbrain or this mesencephalon. So these pools in there, substantia nigra it's called. Okay, substantia nigra is a pool of dopamine. Okay, so let's say you have 100% full of this pool. You don't have Parkinson's. Let's say you have 90% full of this pool. You don't have it. 80% full of the pool. You don't have it. 70, 60, 50, 40% of this pool. So you still have 40% of your dopamine. You still don't have this sign, this symptom here. But there's three things, okay, that the research shows unequivocally that you can detect if you're on your way down that Parkinson's highway. Okay.
Really?
Number one is decreased arm swing.
Really?
If you're walking down a hall, you can detect this 15 years, that's what I was going to tell you before, 20 years before you even get the tremor. Once you get the tremor, okay, I'll tell you what that is, okay?
Okay.
That how low you are in the dopamine pool,
boy.
right?
Yeah.
So as you're walking, if you don't have any arm swing is huge. It's so diagnostic, it's so valuable. If you're just walking like this, no arm swing, okay, it tells us that you have rigid joints up here, okay? Rigidity is one of the earliest signs of Parkinson's.
Really?
Number one. Number two, constipation. And number three, decrease in smell. If you have those three things, if you say, I can't really smell as well as I used to, or I'm constipated, or I don't have arm swing, I mean, people don't know this, but, but those three things, if you can feel yourself going down those, if you can feel those things, okay, and you know that you have those, then there's a high probability that your next step is going to be this little hand tremor, okay, this shake.
That's the last.
That's
like the symptom.
What happens is now, okay, you have 40%, you don't have the tremor.
Okay.
But you're not paying attention to if I can smell the roses or I'm constipated, maybe I'm not eating enough fiber, right? So this is how people think. And but what's really happening is you start to go down this, if you have all three. I'm not saying that if you're constipated you got Parkinson's,
No, I'm getting it.
But I'm just saying
I'm getting it.
Yeah. If there's a history or something going up, family history, but you can get down to this, down to the point, once you get to about 30% dopamine, the second you cross over to 29%, this is what happens, okay? Now you go to the neurologist. The neurologist says, hey, you got Parkinson's. We're going to give you this medication. It's called a synthetic dopamine. And what we're going to do, it's like about 5%, okay? So now you got 29% dopamine. This is an example. I'm just
and it's a synthetic.
Synthetic. So now you get 5% more. So now you went from your 29, your natural 29%, plus 5%. Now you're at 34%. What happens? Hey, I don't have a tremor. It's working. Okay. Now another year goes by, or 6 months go by, or 18 months go by, and now you have 5 synthetic 29, 5 synthetic 28, 5 synthetic 27, 5 synthetic 26, 5 synthetic 25, 5 synthetic 24, and now the tremor comes back because now you're still degenerating. okay, you're going down that Parkinson's at 90 miles an hour, okay? What our job is to get you to go down. I'm not going to stop it, okay?
No.
But what we can do is we can get you to go 40 miles an hour or 30 miles an hour just by doing certain exercises. And there's certain things that you can do to actually stimulate certain areas of the brain that may be able to slow it down, right? So
I've noticed you get to the root of it. This is who you are. This is your belief and your findings. It isn't to medicate. It isn't, I mean, I'm not against any of that either. If you need it, I get that. But I think you go much more deeper to the core of finding what is making this happen. And this is where people are making the mistake. And I said this in my video, even in my 2019 prediction. Listen to your body. Pay attention when it speaks to you. If something is off, don't take the word of even some doctors that'll say, it's okay, you're going to do this, you're going to be that, take the meds, da-da-da-da-da-da, and it's still not working right. Pay attention. Listen to your gut. Find out. Be proactive.
Right.
And you get to the root of it. See, I'm big on stuff like that.
So this is...
But this is important. I commend you for that.
This is not like George anatomy.
No,
I didn't make this anatomy.
No,
this is neuroanatomy. This is the same anatomy.
Yeah.
This is the same anatomy that medical doctors learn, that osteopaths learn, that physical therapists learn, that chiropractors learn, that massage therapists. This is neuroanatomy. These are the pathways, okay? This is the road from the hand to the brain, back down to the hand. There's a mosquito on my arm, I got to slap it, okay? There's a pathway. It's like the 294 in Chicago, okay? That's it. Okay, now, is that 294 under construction? Okay, does it have potholes? Are there lanes closed? Well, we got to fix the potholes, we got to open the lanes up, we got to make sure we keep driving that same pathway. Medication does the exact same thing, okay? It'll drive the pathways, but sometimes they don't fix the potholes.
I agree, right.
Same with vitamins though. Vitamins are very dangerous. Vitamins are drive the exact same pathways that medication drive, and the problem is that a lot of these vitamins are not FDA approved, or have they not even been studied. Okay, the drugs, at least they've spent $2 billion to say, okay, look, this drug is meant for this, okay? It works for this, but here's all the contraindications and all the side effects. So it's telling you, look, we can help this, but there's a probability you're going to get all these things too, okay? Vitamins say, we can help this, but we don't know what the side effects are. And all of a sudden, vitamins are very, I mean, we have a few supplements that we sell here. I'm not a big vitamin guy, but there's stuff that we do, that we sell, that we love, that is evidence-based and double-blinded. And but the number one thing that I love the most is fish oil, omega-3s. That is the most highly studied supplement in the world.
Can you take that if you're allergic to shellfish?
I'm not sure. We're going to have to ask the functional medicine docs that we have. So.
Okay, now you brought that up. Great, a great point. A functional medical doctor. Educate us on that.
So functional medicine is basically, and I wish that we had one of them here right now, but basically,
which you do have on
we
staff.
have we have two here, but I wanted them to tell them
you've got it all here.
So, but our functional medicine docs, will do a very comprehensive blood panel to find out. Look, we're not just going to do a CBC and check your cholesterol. We don't care about cholesterol. My feeling is, I've read a lot of books on cholesterol, and the number one cause of what I believe, my belief is the number one cause of all issues is inflammation.
I agree.
It's not cholesterol. Okay, you can have 300 cholesterol, but if you're not inflamed, you're gonna wipe it out, right? The problem is the majority of people in America and in Canada and now in Europe and all other countries, they're super inflamed. And what's the number one cause of inflammation? Sugar. Sugar is it's almost like if this is the artery, okay, this is the endothelial lining of the inside of the artery, and you've got cholesterol going through. The best way I can explain it is if you eat sugar, okay, it causes inflammation on the lining of the artery, right? So what will happen now is, let's say it has a charge on. Let's say it has a positive charge, okay, And I don't know if it does have positive or negative. Well, let's say this is the example that I'll give. And now you have this cholesterol that's a negative charge. It's going through, boom, it gets stuck. Okay, and it gets stuck, and it gets stuck, and it gets stuck. And this is how you start to get these clogged arteries that they talk about. And just imagine, you know, at least the coronary arteries are pretty big, okay? The brain arteries, they're like hair thin. So if you start getting an inflammatory response in the brain and the outside parts of the brain and the gray matter, now you got these tiny little mini strokes. You may not even feel them, okay? And I'm not talking about TIAs. You may feel that, but I'm talking about these micro strokes that just kind of start to damage a little bit of the outside of the brain. This is all an inflammatory response. And what they do is they'll say, hey, look, it's a $5 test. Okay, check for homocysteine and CRP and see what these.
So what kind of a test is this called?
It's just it's basically a comprehensive metabolic panel. But a couple of the tests that are super important that I find important, okay, are like homocysteine. Well, let's go to CRP. CRP is just an enzyme that if I say, you know, I feel like I got a little bit of chest pain right now, and I go, it's all right, I'll wait it out. And then maybe 3 or 4 days I go to the emergency room and say, you know what, I'm just going to go take a look and see what happens. They put the leads on you and say, no, you seem pretty good, and they draw the blood. My CRP level will be low. Okay, there's no because they didn't go right away. Had I gone right away, and if I had a heart attack or had some sort of infarct, okay, that CRP level in the first 72 hours would have been through the roof. It would have been thousands, right? It would have been super, super high. So that gives you that CRP is an acute response to an inflammatory response, right? Homocysteine, on the other hand, is more of a bigger window. It'll say what your homocysteine levels are. It should be between 0 and 15 is kind of the lab range, okay? Ideally, you want it between 6.5 and 7.5. That's the optimal range, okay? So what homocysteine says is, how inflamed have you been over the last 6 months? Now you know, okay, I've been pretty bad. I've been eating, Snickers bars or candy bars or whatever. And so I've been inflamed, or I've been eating a lot of high glycemic sugars. So that's the inflammatory response. So homocysteine is a very they take this into consideration. Say, okay, look, you got to decrease your high glycemic sugar intake, increase your fatty foods or your good fats. Increase your protein, decrease your carbs, and you go on a very specific diet. And some people love the ketogenic diet. Some people love the paleo diet. Some people love the Mediterranean diet. But some people, the ketogenic diet, which I'm a big fan of.
I am too.
It's not good for some people.
Yeah,
okay?
that's true. It doesn't, there's other complications that come through.
Exactly.
Like
So
something gets off with them.
Yeah, exactly. So you'll need other forms of other types of foods, other carbs maybe to go in there and combat any negativity there. But ketogenic diet is one of the first lines of intervention for epilepsy. You go to the first time I read this, and you go to one of the best epileptologists in the country. He's here in Chicago. You go on his website, you'll see, go on a ketogenic diet. That's what it says right on his website.
So a functional doctor is able to see all of that.
See, as much as well educated as they are, that's what they're able to pick up.
Wow, okay, I'm impressed with that. I am, and I think, I do, and I get that sometimes insurance doesn't cover all of those things, and it's hard for people to say, well, I can't do this. But the way I look at it is, I would rather not do something else, make the investment, because you're doing this long term. Right. This is your investment in you. Right. And so, that's important.
So we get patients, and I know insurance is a big. People get dependent on insurance, which is,
I get it too.
Which I understand. It's expensive.
Very much.
And we've had. I'll tell you just a little story about some kid that we had that had come in, and he was a toe walker.
Oh,
Okay.
I'm very familiar with that. Yep.
So, but he wasn't autistic. He wasn't. He wasn't on the spectrum. At least he's very young, 3 years old. So I'm not sure. But he was a toe walker, and the parents were very concerned about can get him off his toes. Can you do that? I said, well, we can check. We have certain things where we might be able to remediate certain primitive reflexes to help him out and do this. But they'd have already been going to this physical therapy place that apparently specializes in toe walkers, okay? But the reason they went is because they had an HMO, okay? So they've been going for 18 months, no results, but they keep going because it's free, okay? Well, we saw this kid for 3 days, okay, and the kid's walking flat-footed right now.
Yeah.
Okay.
Yep.
So
I believe it.
But they had to pay out of their pocket to come here because we're not in these networks. So now the parents were going, well, we're spending a lot of money. I said, well.
Yeah, but look what you just got in 3 days.
Yeah, but you didn't spend any money and you got nothing.
Exactly.
And you wasted 18 months.
Exactly.
Okay?
Look what you got in 3 days.
Yeah, but and it's not about for us. I just love when I see, like I've had so many awesome cases where I'm thinking. Sometimes when I first started this, I started doing functional neurology about 10 years ago, and I didn't know anything. I was a chiropractor. We had a big physical therapy chiropractic office, and about 5 years ago, I just switched.
It's funny because before we started taping this, what did I say to you in the hallway? The fire in your eyes, the passion. You light up like a kid opening up presents at 6 years old.
It is so.
I see it. It's all around you. You definitely do it for the passion, for the connection of people to help them. This is a big thing. I don't often get to see that, okay? And that excites me to see somebody doing it. From your core, it's coming through.
I like that.
I see it.
I love it. I mean, it's just like, especially when I try something, I don't know if it's going to work, but let's see if it works. Okay, we'll do an exercise, we'll do something. And then I have a measurable difference where, I'll spin them in a chair in a certain direction. And I'll say, well, I've already measured objectively that this person's optokinetic stimulation to the right and down was a mess. Okay, what does that mean? Well, we treat a lot of kids that play hockey. We treat professional athletes. We treat, people off the street. And when you're skating on the ice, okay, because I'm a big Canadian hockey guy, right? When you're skating on the ice and you're going around the rink, okay, what's happening is the stands are going the opposite direction, the seats, right? So you get this optokinetic stimulation.
I never thought of that.
And that's exactly why when these guys get hurt, and there's been some best players in the world get concussions, right? Could not play for 9 months, a year, okay? And literally they were ready to call it quits. And like 10 days of this type of therapy, 11 days, the kid goes back on the ice. I don't know if I can say his name, but he's probably the best hockey player in the world right now. And he's back on the ice skating and
that's
just killing it.
And that's due to you and what you did.
Yeah. Well, it's not me personally in this case.
Your technique.
One of my partners actually helped in that case. So.
That's wonderful, and I love that. But that's part of you. Speaking of that, you have many, many success stories. Talk about the one that you were showing my producer and myself, the girl who didn't have the balance really well. Talk about that.
Yeah, so this girl, she was, I think at the time she was 15. She was a volleyball player and, great student, good social life, loved the girls, hang out with friends, just a great, great life. She was playing volleyball. This is sort of the case in a nutshell, but playing volleyball, she fell, somebody landed on her, she broke her jaw, okay? She got this concussion, and she ended up getting this, she got the concussion, she got dysautonomia initially. And
which
dysautonomia is basically a short circuitry of what's called the autonomic nervous system, where like normally you should be, and this is approximately what the autonomic nervous system does. It's like you have what's called a sympathetic nervous system, which winds you up, okay, which is this fight or flight mode, and they have a parasympathetic system, which is this rest and digest and relax mode. And so 90% of the time, you should be in parasympathetic mode, nice and relaxed. Okay, and 10% of the time, you'll be in this sympathetic mode, which kind of keeps the tone of the arteries and you on alert, sometimes. But when you go, if somebody scares you, okay, and or you're in a dark place and you hear some bear growling in the woods and you can't really see what's happening, what ends up happening? Your
palpitations,
your heart starts racing.
Yeah.
The reason it's starting to race is because you're going into sympathetic mode, which is protective mechanism. It's emergency, right? So what is this heart doing right now? It is pumping all the blood. It's putting you in sympathetic mode, which was fight or flight. Okay. So what is the word fight or flight means this? You're gonna fight the bear, okay, or you're gonna flight the bear. You're gonna run as fast as you can. So the best way to do that, the most efficient way to do that is, let's pump all the blood and all the nutrients and all the oxygen to the muscles that need it and get it away from the center of your body for right now. That's why the heart starts pumping and it shunts the blood out to the periphery, right? So if you just had a hot dog 10 minutes before, okay, and now you're in fight or flight mode, the hot dog's going, hey man, we got a hot dog down here. Okay, it sends a signal to the brain. The brain says, we got a bear chasing us. So I'm gonna come back and digest a hot dog after I run away from the bear. Okay, so after you run away from the bear, you're all good, you're calm, then you go back into parasympathetic mode, right? So all the blood goes from the periphery back to the center of your body, and you rest and digest and repair anything that was injured, and now you have the majority of the blood in the center of your system where the nutrients are and the healing mechanism is, right? So that is a normal autonomic parasympathetic sympathetic result. The autonomic nervous system is broken down to sympathetic and parasympathetic. When you have dysautonomia, okay, the sympathetic and parasympathetic aspects of this nervous system are kind of short-circuited. Okay, so
this is what happened to her.
This is what happened to her. Her heart rate, her resting heart rate was, sitting down, was like 120 beats a minute. Okay, which is probably double what it should be. Okay, when she stood up, she goes, "Oh, I feel lightheaded," and what was happening was she couldn't pump the blood from the bottom of her feet up to her brain. Okay, so she gets lightheaded, and she'd have tachycardia, she'd have gut issues, low blood pressure, and so low blood pressure. So the autonomic nervous system controls the heart rate and the blood pressure and all these things, and so she had this dysautonomia, right? So we corrected that, and she also had this balance issue. Okay,
I noticed that. That was huge to me because she kept like rocking.
Yeah,
she couldn't do it.
She couldn't walk.
Yeah.
She couldn't. So she'd gone. Before she came here, she'd gone to world famous hospitals.
Okay.
And they said, well, you have dysautonomia. Okay, which is called POTS. Okay, postural orthostatic tachycardia.
And you educated me on POTS.
Yeah, we treat a lot of POTS.
I know you
here.
do.
And so, but this gait that you have, the diagnosis that they gave her, was called a functional gait disturbance, which basically means that you've convinced your brain that this is normal, so just keep walking like that. Because people that have these things really have these things. They really believe they have these things, okay? But they just blew it off. Said, okay, well, you have this functional gait disturbance, okay? We think that you can correct it by yourself. You're kind of making it up, but they didn't give her any guidance on how to do it. So anyway, she came here and we fixed her dysautonomia, but she was still wobbling back and forth. She'd walk back and forth, and so we treated her for longer. We got a lot of stuff better, but we still couldn't get this. Imbalance better. And so my colleague and my partner, he was reading some stuff, and it came up that. He thought that she had inter-cranial hypertension, which basically means that the pressure in her brain, possibly from the dysautonomia, might have been too high, which might have been causing the pressure in the brain to cause this disturbance, this gait disturbance. And so, so I've got a buddy of mine, he's a neurosurgeon. I called him up. I said, hey, what? Can you do this for me? Can you do like a lumbar puncture? And he said, well, does she have this sign? And I looked, I go, she doesn't have it. He goes, I can't do it. Okay, he goes, send her to an ophthalmologist, see if she's got this papilledema. It's called the swelling of the optic nerve, right? See if she has that. And I said, well, she goes there, she doesn't have it. So
which you already said she didn't.
She didn't, right. So 94% of the population that has intracranial hypertension has this papilledema. But 6% that have intracranial hypertension do not have papilledema. This is what the research shows. So now we're thinking, did she fall into this 6%?
Yeah.
Okay. So, because now we just said, but everything that we looked at, there's an MRI that we got that showed that there's some like normal variants of certain areas of the brain and fluid going up to the brain. And so we called another guy. The other guy said, I'm not going to do it. And so finally, she got it done somewhere here in Chicago. Somebody said, well, what do we got to lose? So he does the normal intracranial pressure for a normal person is somewhere between, I think, 7 and 15 millimeters of mercury. Okay, her initial pressure was 30.
Of mercury?
Like the pressure. So millimeters of mercury, it's like a thermometer, right? Except it's for pressure. So her pressure was double, almost triple what it was normal supposed to be.
No wonder she was walking like this.
So when he sucked out the cerebral spinal fluid, it decreased the pressure in her spinal cord. He got it down to about 19, which was still above normal.
Wow.
Next day she came in, walking straight as a bullet.
Oh my God.
Okay, so now
that's
now
amazing.
Yeah, it's pretty, but
it's incredible.
That's just because we ran out of stuff to do too, right? So we don't have the answer for everything, but
you got her to walk normal.
At least we knew where to send her.
You did great though. I mean, I saw the footage, and the footage is amazing to me, and that was something to see.
Yeah, it's pretty cool stuff.
That's the reason you do what you do.
Yeah.
When you see this and you see how they come in and how they leave you, they're two different people.
Yeah. Sometimes I surprise myself.
I don't blame you.
4 or 5 years ago, people would call and say, well, I have this, and this. I'm going, well, how many doctors have you been to? No, I had one lady who'd gone to 44 doctors, migraines every day for the last 20 years.
Wow.
And she came to our office, and within 3 weeks, she was migraine free.
Now, do you hear that, everybody? Migraine free. So if you're suffering from migraines, you don't have to suffer through them. You do not, because this can be corrected.
Yeah. And so here's the other thing too.
Yeah.
This is what we don't do here.
Okay.
When a patient comes to us and they've been if it's been suffering for a week or 10 years or 20 years, I'll sit them down and say, listen, we are going to do a whole bunch of the first day that they're here for 3 hours. We're doing a super comprehensive exam that takes about an hour. We're doing all these diagnostic tests that takes a couple of hours, and we get a lot of data. And we are able to see every corner of your brain, every aspect of your body, and say, okay, look, this is what we're finding. This is what we found. This is what we're going to treat. Okay. Sometimes the person with Parkinson's and the person with migraines has the exact same findings. So I'm going to treat them like that. But one person with Parkinson's, another person with a different migraine might have different findings. So we're going to treat whatever we find. We're going to treat. Okay. So if we notice that this person has a demised frontal lobe, we're going to give them exercise to increase that frontal lobe, whether it's Sudoku puzzles or saccadic eye movements or pursuits or spinning vestibular stimulation. Okay. We do visual, vestibular, and proprioceptive therapies, and we'll do neurofeedback. We do a whole bunch of stuff. But so we tell the patient, look, we're going to get objective findings, okay? And today we're going to see that, hey, your eye movements to the right were a 2 out of 10, and your latencies to the left were a 3 out of 10. And these are just made-up numbers, but this is what I'm telling you. We have these numbers, 2 out of 10, 3 out of 10, 1 out of 10, 4 out of 10. What we're going to do, okay, is we're going to treat you with what we found for 10 days, 10 or 12 days, somewhere in that neighborhood, okay? If in 10 or 12 days, well, first of all, we're going to then repeat these diagnostic tests, okay? And I'm pretty confident that a lot of these objective findings will get better, okay? There'll be a 7 out of 10, 8 out of 10, 9 out of 10, 10 out of 10. But sometimes, even though you objectively got better, it didn't translate into subjective improvement. So if you're coming to me and you say, you give me 10 symptoms that you have, okay? And I say, look, Susan, if I had a magic wand and I could just get rid of one of the symptoms, okay? Not that we're going to get rid of one only, but if
Which
I can
would it
only,
be?
which one would it be?
Right.
You say, get rid of my migraines, okay? And on a scale of 1 to 10, okay, what are your migraines every day? Well, they're daily, and I get them between a 4 and a 7 out of 10. I go, okay. My goal, if I tell you, look, if I can get your migraines to a 1 out of 10 or a 0 out of 10, 1 or 2 days of those 10 days, would that be an improvement? A lot of people say, oh my goodness, I could live with a 1 out of 10, right?
Yeah.
Okay. But if you come back and I show you on day 1, you were 1 out of 10, 2 out of 10, 4 out of 10, all these objective findings were all in this zone, and now all the objective findings are much, much improved, and you come to me and say, Dr. George, I can see, I'm going to make you see it with your own eyes, that this is how you improve, this is what you improve, this is how these exercises we do affect your brain, okay? This is, like I said, this is not George anatomy, this is neuroanatomy, okay? And you tell me, well, Dr. George, I see that I improved everywhere objectively, okay, and today's the 12th day, my migraine's still a 7 out of 10, we're going to X Dr. George off the list and you're out, okay? I'm not going to keep you here for 2 months and say, well, all this stuff didn't work, let's throw another dart over here and see if this works, okay? What we do works quickly, it works to improve brain function, and it's evidence-based. It's in the literature. It's peer-reviewed. It's you know, like I said.
You don't dance around it.
No. This is This is what we do. I'm not making stuff up where I'm saying I'm going to try this. I'm not sure if it's researchers. Some people do this. Some people can wave their hand over patients and get them better. And you know what? This is awesome. What I want is, hey, keep waving the hand over and tell me what happened to this patient so you can publish research on it and get it peer reviewed. And but what we have right now to make us legitimate is peer reviewed research that is global, that the medical community understands, that the chiropractic community understands, the physical therapy community understands, that the whole medical healthcare world understands. This is what peer review is all about, okay? So, I mean, my job is we've published a lot of papers here also, you know, between all the doctors in our office, we've probably published 50 papers.
Wow!
And these are all peer-reviewed papers. Okay, we of course need to you know, do more, and to make sure that, hey, look, is there something we can do better? Okay, the stuff we do now works great. Well, pretty sure there's probably better stuff that we can do, but we need to document it. We need to be able to peer review. Submit the literature to high impact journals. So I'm not saying, well, I just sent it to Bob's medical journal over here and he peer reviewed and said, oh, this is great. Okay, we need to send it to like Frontiers Neurology Journal, where we've published everything, which is a super journal, or Journal of American Medical Association or British Journal of Medicine. These are the journals that where the research has to come out of. But that's what we do here, and like I said, if you get better after 2 weeks and you say, "Oh, my headache's a 1 out of 10," now I want I'm going to make you make the decision as to whether or not you want to continue. I'm not here to force you to come to my office, and because it's expensive. It's not cheap. Okay.
Like I said, it's an investment long term in you.
Yeah.
That is something
Absolutely.
I need. This is not a Band-Aid. This isn't a quick fix. This is something that you're going to put into yourself. Just like what you said, the prevention of even finding out where your levels are.
Yeah. If you get a baseline, that's all you need. At least we know what where we're at right now.
Okay.
And see what we can do to improve it.
I love that.
Yeah.
And that is the basis, and this is why I was so incredibly grateful that you came on this YouTube segment, Beyond Words.
Yeah, thank you.
I mean that. You are so welcome. I do want to interview you periodically because I know how many findings you come across, and there's more things.
Yeah, there's
and
a lot.
I know there is, and I love helping educate people because this is very important. And I want people to know their options. So many times they don't. They go to 40 or 50 doctors, they go to 7 doctors, and then they come to you and you fix them, you repair them. And they're like, you don't need to spend years of agony
Yeah.
Okay, and you're able to do that, but you're a wealth of information, and God bless you for that.
Yeah, thank you.
I truly mean
Appreciate that.
So you have offices in Wooddale, Illinois, and Chicago.
Yep.
Okay, so how do people get a hold of you?
So you can either go on our website, the Neurologic Wellness Institute.com.
Okay. So I was told you go to the consultation and scroll down and to schedule a complimentary phone consultation.
Right. If you call there, if they call there, if they put the input there, one of our girls will get back to them, and one of our doctors will call. I'll call, or Dr. Drzwicki or Dr. Sass will call. Somebody will call them back, and actually the girls will call you back, and then they'll set the consult time up, and we'll sit and discuss. If we can help, we'll discuss it. If you can't, at least we'll get a kind of an idea of what the issue is, and you know, we do this all the time. We don't accept all patients. Sometimes they're a little too maybe needed to do some more diagnostic testing, like MRIs or CAT scans. So, but if we feel that, you know, we can help, you come in, you do the consultation and the exam, and we'll sit down and say, okay, look, I don't know if I can help everybody, okay, or anybody for that matter. Alls I know is that we've seen a lot of patients, and a lot of patients have gotten better, and a lot of people that, you know, inquire have very similar symptoms that the patients that we've helped have had. And so our goal is, look, the first 2 weeks are my 2 weeks. After that is up to you.
I think that's more than fair.
So, yeah.
I do.
And especially if they've gone for 10 or 20 years to other doctors and they haven't found any relief. This is, we just need to make sure that, you know, you do everything possible to help yourself. So.
I cannot say thank you enough. You educate me every time I speak to you, and I'm so grateful. And like I say, you know, knowledge is power. And when you have that, it gives you options. So I want to say thank you to you beyond words. And I also want to say thank you to the viewers who tuned in. Pay attention to this video. It's a wealth of knowledge, and it's going to, you know, maybe you have to watch it a couple of times, because if it's not you, it's somebody you know. But there are tremendous amounts of people that can benefit from the knowledge that Dr. George Michalopoulos was gracious enough to sit down today and talk to us about. So thank you for watching. I hope this was enlightening, and look forward to many more segments. All right, all the best. Take care. Bye-bye.